afternoon, everybody. Welcome. I'm Mark Pauley, Co-Director for the Interdisciplinary Nursing Quality Research Initiative, or INQRI program. As its name suggests, INQRI is a program that believes strongly in the merits of interdisciplinary collaboration, something that begins with our own leadership team. On behalf of that team, comprised of Mary Naylor on the right there and Lori Melikar on the left, I'm in the middle, and Heather Kelly, who is not shown, I would like to welcome you to the fifth webinar in our series on dissemination and implementation of evidence-based practice. INQRI is a program of the Robert Wood Johnson Foundation that was launched back in 2005 with the purpose of generating, disseminating, and translating research to improve the quality of patient care by supporting interdisciplinary teams of scholars to address gaps in knowledge about, in particular, the relationship between nursing and healthcare quality. During our previous sessions, we've shared with you some of the artistic interpretations of discussions held during the INQRI annual meeting. This is an entry in our art collection suitable for framing. The piece we're sharing today is from a panel presentation held during our second meeting. The panel brought together stakeholders across disciplines to explain to researchers how to catch their eyes and how to catch the eyes of potential end users of their work. From the very beginning, we've asked our grantees to focus on the impact of their research. We wanted them to consider, even before they launched their projects, how to make sure their findings could be put into practice. Today, you'll be hearing from Marita Titler on behalf of Paul Conlon and their team. Dr. Titler will share the ways they've focused on putting valuable evidence into practice to prevent patient falls. As I mentioned, this session is the fifth in our series on dissemination and translation. Here's the preview of coming attractions. You can access the prior four sessions on our website, and we hope you will, and that you'll also participate in the final session scheduled later this month. Details are on the screen. You can register for this session at www.inqri.org, where you can also review the previous webinars. On previous calls, we've also given you the opportunity to learn more about the distinguished members of our National Advisory Committee. These trusted colleagues are committed to improving health and health care for all Americans and to ensure that nurses, as the largest group of health professionals, have a recognized central role in that effort. We brought together once a year at our annual meeting, INQRI researchers have had the opportunity to network with NAC members who joined invited guests to provide feedback at that meeting, advice, and encouragement to enhance their work. Our NAC members have generously made themselves available throughout the life of the program to support our grantees, advise our leadership team, review proposals, assist in dissemination, and much more. Joining today is one of our distinguished NAC members. In just a moment, Laura Karamanica will introduce you to Marita Titler and her team's work on implementing an evidence-based risk factor fall prevention bundle. In the meantime, though, it's my honor to tell you a little bit about Laura. Laura Karamanica is the Vice President and Chief Nursing Officer at WellStar Kennestone Hospital. Laura has more than 20 years of senior-level leadership in acute care settings. She joined WellStar in June 2011. Laura moved from Westchester Medical Center in Valhalla, New York, where she was the Senior Vice President and Chief Nursing Officer for the medical center and the Executive Director of the Institute for Nursing Excellence since 2007. Prior to that, she was the Vice President for Nursing at Hartford Hospital in Hartford, Connecticut since 1999. In addition, Laura serves on the American Organization of Nurse Executives Board as past president, in addition to chairing their International Committee and Nominating Committee. Laura received her diploma in nursing from Hartford Hospital School of Nursing. She received her Bachelor in Sciences in Nursing from the University of Bridgeport, her Master of Education in Nursing Administration from Columbia, and her Doctor of Philosophy from the University of Connecticut. Laura is certified in nursing administration by both the American Nurses Association and the American Association of Nurse Executives, in addition to being a fellow of the American Academy of Healthcare Executives. So, Laura, I want to thank you for serving on INQRI's National Advisory Committee since the beginning, way back in 2005, and for leading our session today. I'll turn it over to you.
Well, thank you, Dr. Pauley, and thank you all for allowing me to introduce this incredible research team. Their work is really making hospitals today safer. The background for the study that we're going to hear today is related to the fact that accidental falls are the most commonly reported patient safety incidents in hospitals today, with rates from 2.9 to 13 per 1,000 patient days. Up to 30% of falls result in injury, including death. Interventions targeted to the patient's fall risk factors are necessary to reduce falls, but few hospital fall prevention programs have implemented such an approach. The purpose of this 18-month study that we will hear about today is to really learn about a prevention program that implemented this approach to fall prevention and also reduce the number of falls in hospitals. The interdisciplinary team which led this research study is Dr. Maria Titler and Dr. Paul Colon, and now I would like to turn it over to Dr. Titler.
Thank you very much. So it's very exciting to be here to present the findings of our research. I want to make sure that I thank Heather, Mary Naylor, Mark Pauley, and Lori Milliker for the great work they have done with the INQURI program in general in leading this very important research initiative, and to Robert Wood Johnson Foundation. So our study purpose was to implement fall prevention interventions that target patient-specific risk factors for falls, and then evaluate the use of those interventions on fall rates and fall injuries. As Laura said, accidental falls are the most common reported patient safety incident in hospital, and the beneficial effects of fall reduction increase when interventions are targeted to patient-specific risk factors. However, few hospital programs actually focus on patient-specific risk factors and interventions to mitigate patients' risk. So our study had three aims: to compare fall rates, fall injury rates, and types of injuries from falls prior to, during, and following implementation of what we're calling our Targeted Risk Factor Fall Prevention Bundle, evaluate the level of adoption of evidence-based targeted risk factor fall prevention bundle both at baseline and follow-up, and then using qualitative methods get feedback from those involved in the study of how the program went and how the study went. We have three sites, a 471-bed academic teaching hospital, a 243-bed community hospital, and a 90-bed rural hospital. And we had 13 adult med-surg units from those hospitals. So N of 13 is the units, and you can see on this slide the age prior to, during, and following implementation of the patients cared for on those units. The average bed capacity was in high 20s, average daily census in the low 20s, and RN skill mix about 75%. The conceptual framework we used for this study was to first recognize that many places have a universal fall prevention program in place in which they do things like keeping the hallways clear. They then have general fall prevention interventions based on the patient's risk factor score, which are things like putting a sign on the door. Where we really wanted to focus was this central area of targeted individual risk-specific interventions that are guided by the patient's specific risk factors for falls. So we focused on interventions that reduce or modify the individual risk factors. Fall risk tools are currently used by many, but how we are using them may not be all that helpful if all we do is do the score and tick the boxes and not really look at the patient-specific risk factors. So that's what we were focusing on. Our implementation model is a model we've used in other studies based on Rogers' diffusion of innovation model that says the characteristics of the evidence-based topic, in this case falls, how you communicate it to users, where they work, affects the adoption of those practices. So for this study, our evidence-based practices were the fall risk-specific interventions. Our implementation interventions that we used for implementing those were quick reference guides, posters, and key messages. Our communication implementation strategies were use of opinion leaders, one at each hospital, a change champion, one on each unit, outreach visits about every 5 to 6 weeks to the sites, doing rounding with them and point-of-care coaching. At the beginning, we had a train-the-trainer program and then staff education. We also discussed audit and feedback data with the nurses and pharmacists, and also looked at their baseline data with them, and then had monthly teleconferences. We also had a senior administrative program at the very beginning to educate the senior leaders and nurse managers and meetings with the pharmacists, and then our outcomes were fall rates, fall injuries, and use of risk-specific interventions. So that's how we applied the model in terms of implementation. The next slide gives you somewhat of the dates. So we had our train-the-trainer program in March. The kickoff meetings at each site were in May, and then we started monthly teleconferences, and as I said, the quick reference guides and key messages. The next slides, this next slide is an example of the quick reference guide. So this one happens to deal with mobility. And so we looked at what are the indicators that they are at risk for falling from mobility issues, what are the interventions, and what are the hints and tips. So we did these quick reference guides for each of our conceptual areas, which I'll show you more about in a minute. This one was around elimination. So here are the indicators that they should look for. Here are suggested interventions, and then hints and tips. So they had one of these for each of the conceptual areas. And here's one on pharmacological agents. Bob Ripley, who is on the phone, really helped us a great deal with this. So we looked at indicators. We had attachments for high-risk drugs and what they could do to prevent those, and then hints and tips. So that's how the quick reference guides were laid out. Here's kind of a fun slide. This particular site bought T-shirts with their role on the back and their name, and unveiled those at their kickoff meeting. All of the sites had a dedicated bulletin board that they put information up on. This one from one of the sites put up the initial information, and then they posted additional information there. This one happens to be in their break room. This particular place made this poster themselves. They really wanted people to think specific to risk interventions, and so display that as well. Excuse me. We also developed a set of posters which were basically laid out with information that they could use. This one is about falls overall. And so, for example, do you know that 20 to 30% of adults who fall suffer moderate to severe injury, and then the consequences of falls? This one gave people information about patients' perceptions on falls based on Patty Dyke's work. It says, I knew I was supposed to call for help, but I didn't want to bother them, the nurses. So what they could do then as caregivers, clinicians, to help reduce the falls, the actions. This one was geared towards nursing assistants, from Patty Dyke's work. So nursing assistants, for example, receive little information about patient-specific risk factors for falls and fall preventions, leading to avoidance of answering call lights. So what can you do as clinicians is include this in report. So these were key messages that we gave. This one was on urinary incontinence and patient falls. What's the problem? What are the facts? And what can you do? If anyone is interested in receiving these, I do have them electronically. I'm happy to share them. One of the places had a nurse who was very artistic, and so they took these posters and translated them, if you will, into key messages on a theme called Dottie. And this one is when you're at high risk for falls, the message is that you should stay within arm's reach. And she says, and sometimes you wish you had longer arms. So that was really to capture the attention of the staff. Our dependent measures were fall rates. that you can see on this slide, number of inpatient falls multiplied by 1,000, fall injury rates, and types of injuries. We also had a nurse questionnaire at baseline and follow-up that had 2 tools on it, the nurse's use of research findings in practice and the stage of adoption scale for ambulation, delirium screening, medication review, and post-fall huddles. This is self-report of nurses' use of research and use of research to guide use of interventions for the stage of adoption scale. We also looked at medical record data, abstracted medical record data. So if a fall risk factor was present, we then checked to see if an intervention was, if there was an intervention to address that specific risk factor. We did 10 patient records randomly selected per unit for 3 months baseline and the same at follow-up. We did test our medical record abstract form for both content validity and inter-rater reliability. And we looked at, these are the conceptual areas we looked at in this study for interventions that were risk-specific. Mobility, so for example, the number and types of risk-specific interventions. Did they get ambulations with assistance or physical therapy referral? Delivered for those with specific fall risks, so if they had gait issues. And we looked at these within and across each category by patient date. So these are the categories: mobility, toileting, medication, mental cognitive status, and risk for injury. Our focus group at the end of the study, we had 38 nurses from the 13 units within 1 month following the implementation phase. We tape recorded and transcribed those interviews for analysis. Our statistical analysis included descriptive and multivariate analysis, as well as qualitative methods looking at minor and major themes. We did do pre-post comparisons as well. So for our results, this is just the descriptive data in terms of fall rates. Those did go down if you look at them over time. And then the injury type, I'm going to move on to the next slide because it's easier to see. So what we found, although this was not statistically significant, the minor injuries went up and the moderate and major injuries went down. And that's what this slide shows. We had no deaths from falls at any time during the study. Now, in terms of fall rates, so this is a multivariate analysis looking at change in fall rates over time. So they did go down, but the p-value was only 0.09. I would remind you that our N for this was at the unit level, so the N was 13. The percent of RN skill mix and diagnosis severity were also significant. So basically, we had a 22% reduction in fall rates over time. As diagnosis severity increased, fall rates increased, and as RN skill mix increased, fall rates decreased. This is the level of adoption, just the characteristics of the nurses pre and post. So nurses were in their 30s, had worked from 8 to about 12 years, mostly female, mostly white, and the education group was mostly ADN or diploma. So in terms of the one scale that asked you, do you use research findings in practice, we did have a statistically significant difference between pre and post. Prior to implementation, we had a smaller group in the adoption implementation phase of using research findings for fall prevention as compared to post. And our N was 154 at baseline and 138 post. In terms of stage of adoption, we had a change in use of ambulation based on research evidence and a change in use of post-fall huddles. Excuse me. Delirium screening and use of medications did not change significantly based on self-report. Now this, I'm going to go a little bit slower with you, but this looks at whether or not risk-specific interventions were used. This is all of those in the mobility group. So patient days is the number of patient days where the patient was at risk, and then the rate is did they get the intervention if they were at risk. So again, this is the number of days that they were labeled at risk for mobility issues and whether or not they got an intervention to address that risk. And we did have a significant change in the mobility group, a significant change in the toileting group of interventions, not a significant change in the medication group. We did have a significant change in the mental cognitive status group, and a significant change in the risk for injury group. So I'm going to take some examples from this group, this mobility group, and show you exactly what they are. So if someone had gait instability, lower limb weakness, or required assistance getting out of bed, did they get ambulation about 3 times a day with increasing distance? And you can see we did not get a significant change in that in terms of the p-value. In terms of attending physical therapy, that p-value, we did get a significant change. Assistance device available, a significant change. And lower limb weakness and rounding instituted a significant change. Now, the rate per 100 patient days means that for this group, about 30% of them really, or 30 out of 100 patient days, did they have an assistive device available when they had lower limb weakness. So even though we got a significant change here, I would point out that some of these, even at post, are not where I think they probably should be. This is the elimination group. So if they had incontinence, were toileting rounds instituted, and you can see that was significant. Was a bedside commode present? That was not significant. Were diuretics given in the AM? That was significant, or the change increased over time, as did laxatives being given in the AM. But again, some of these are lower than I would expect them to be for patients who are at risk with elimination issues, even at post. Now, we did a multivariate analysis to control for a number of things, including the hospital that was not significant. And the ones I've included here are severity of illness, case mix index, age, and RN skill mix. So this is basically telling you the time. Was the time factor significant? That is, did we get an increase in the expected direction over time after controlling for these other covariates? So physical therapy attended was significant, as I already mentioned. Toileting rounds was significant, diuretics given in AM. So I did not put in all of our multivariate analysis. I would tell you that what we found without the covariance in the model, we did not get a lot of difference in terms of degree, in terms of significance when we put when we put the covariates in the model versus not putting them in. I would also call your attention that RN skill mix was significant in a number of these, all but one. And it kind of makes sense. So this one in toileting rounds, as the percent of RN skill mix went up, the toileting rounds went up. So they are somewhat related to, they make sense in terms of their direction that they go. In terms of qualitative analysis, we did thematic analysis and found that collectively nurses constantly talked about changes in practice culture. One of the things, they really came around three themes that supported that: coaching and education, collaboration, and mindfulness and use. So in terms of mindfulness and use, they say, I think people, nurses, are more aware. It's not that we were not aware before, but it's part of our culture now. It's patient-specific fall prevention strategies are kind of in everyone's face now. Collaboration, all the different disciplines that work with the patient are now much more aware of the fall risk of the patient, and coaching and education. The information about the fall study was discussed at our shared governance meeting, which is where all of our major leaders and staff nurses go. So in summary, the implications are this implementation strategies with these kinds of fall prevention strategies seem to improve care around fall prevention. Nurses were certainly enthusiastic based on our qualitative data about participating in this. These are some of our slides from one of our sites. One of the particular units, as I made rounds to these sites about every 5 to 6 weeks, one of the rehab units had drastic reductions in falls based on what we were doing in this study. The other implication I would say is this was a pre-post study, and we really should see if these findings hold up with a comparison arm. We should also see if these findings hold up if we have more units in place. In other words, do the fall rates become less than 0.05? I think that this has moved, certainly these three hospitals, to really thinking differently about how they prevent falls in terms of looking beyond the fall risk score into looking at the patient-specific. So I would leave you with those implications. I wanted to acknowledge Robert Wood Johnson for the funding to do this study. The participating units and staff were absolutely phenomenal to work with. Margie Reynolds from Trinity Health was very instrumental in helping us do this study, as well as Bob Ripley, Director of Pharmacy Operations and Medication Cycle Improvement. So that concludes my formal remarks. I would love to have some discussion about the study and what questions you might have.
Dr. Tinkler, if it's okay, I'll start the first question. And my first question is, and all of you out in the audience, be thinking about your question because you're next, is that you did your study in a large academic teaching hospital, in a community hospital, a good-sized one, and then a 90-bed rural community hospital. Was there any variation in the effectiveness with these patient risk indicators across the three hospitals? Did one hospital do better?
First of all, the 400 and some bed hospital was a teaching hospital. It wasn't an academic medical center. It was also a community hospital that takes residents and students, but is not part of a university system. What we did was we really looked across hospitals, with the units being the level of analysis for the study. When we put the hospitals in as control factors, and they frankly did not show any variation in terms of controlling for that. No variation by hospital.
No variation. Okay, thank you. Okay, audience, do you have a question?
Once again, on the phone lines, please press *1 or feel free to submit your questions via the chat feature. Once again, *1 for the phone lines.
I have a question that's been submitted on the chat feature. Marita, could you speak to some of the IRB challenges associated with conducting a study of this size and across so many sites?
Sure. So we had, for this particular study, for this particular study, we had to get IRB approval at the University of Michigan and IRB approval at a larger hospital, and then the other two hospitals used our University of Michigan IRB as their IRB. So it wasn't too bad for this study, but I will tell you the medical care article in which we had interviewed PIs of all of the implementation studies. They talked quite a bit about the IRB challenges and IRBs not being set up to really understand what is implementation research and does it, and try to kind of use the same criteria as you would from a typical individual randomized trial where you're randomizing patients.
Great, thank you. Another one has come in on the chat feature asking about additional interventions, if there was anything beyond posters and flyers, and if you could talk a little bit more about the educational components.
So we had a two-day Train the Trainer program in the beginning, which included the nurse opinion leader, the nurse change champion for every unit, and some nurse managers, where we went over each of the conceptual, we went over what are the challenges with preventing falls, what was the study about, and then we took each of these conceptual areas of mobility, elimination, cognition, and looked at what are the big risk factors there and what are the evidence-based interventions to try and mitigate those risks. And then we had them meet in teams from their hospital to start talking about how they were going to educate the staff at their place and how when they wanted to have their kickoff meeting and to start developing an action plan. So that was the Train the Trainer program. They also got all of the materials from the training program to use at their local site. So the other components of the intervention are listed in one of the slides. So the opinion leaders, the change champions, outreach visits, meaning going to the sites every 5 to 6 weeks over about 10 months and doing, and that was very fun because you could talk to the staff about what were the challenges they were having with specific components of fall prevention that were related to fall risks. One of the sites actually used the whiteboards in the patient rooms to list the patient-specific risk factors for each patient in that room, and then what interventions they were doing for that patient, and then would update it daily. So the implementation interventions included the Train the Trainer program, the quick reference guides, the posters and key messages, rounding, that is us rounding on the sites. The teleconferences that we had every month were very helpful because the units would compare what they were doing for implementation and how it was going. We gave them data back, so each of the units actually abstracted 5 records a month to look at what were that patient's risk factors and what interventions were we doing. And then I took that data back with me and discussed that with them and showed them the progress of improvement. For example, you have this many patient days, with patients at risk, and only less than 25% of those patient days are getting any kind of mobility intervention. And when so that was really helpful for them to see we have this many patient days at risk, but we're not doing much about addressing that specific risk factor. So that's the audit and feedback. It was very important, I would say, up front to meet with the senior staff and the nurse managers about what is this study about. This really is about improving quality of care. When I went to the sites also, I always rounded with the opinion leader of the site and met with the change champion and the nurse manager of the unit as well. sometimes I would, some of the sites had AM huddles. I would be there in time for their AM huddles as well. So hopefully does that give you more of a...
Yes, I think that's great. I've had another question that has come in asking to describe exactly what the unit-based change champions do. Yep. If they were doing rounds with other staff about fall prevention, or are they simply available for others to ask advice?
That's a great question. So they were responsible for the unit-based education. They were encouraged to find people doing, quote, the right thing. They were the ones responsible for abstracting the 5 records per month, or they and another staff nurse, so that they could see what those interventions were looking like. The change champions often were also the people that the people who worked with the opinion leader, and I think all of these places, they ended up being the part of, if not the fall prevention team for the hospital.
Great, thank you. Paula, do we have any questions in the audio queue?
We do, and we'll take that question.
Marita, this is Margie Reynolds, and
yeah.
Sorry I was late in joining, but do you have any, one of the things we always think about with falls and preventing falls is RN skill mix. Do you have any thoughts about that? I mean, clearly it's got some significance there, but any kind of summary about that?
Yeah, so I didn't put up exactly how much decrease in falls you get for every increased percentage of RN skill mix, because I really need to double check that percentage again and wanted to make sure it's very clear. For some of the places where it is significant, I think it's because it requires some dedication of RNs to at least lead this initiative to look at patient-specific risk factors. Okay, so if you don't have that, then it's really about, I think, the skill set of RNs, not the number of people or even the HPPDs. We have HPPD data, RN HPPD data, and it doesn't contribute in the multivariate analysis. It's not significant. These findings are similar in terms of RN skill mix to other work I've done, and we are thinking about writing a paper around contribution of RN skill mix in comparison to ratios and HPPDs, because it consistently comes up in several studies as being a significant contributor.
Mm-hmm.
A significant covariate.
Yeah. Well, that's interesting. Yeah.
I would welcome other thoughts about that.
Dr. Titler, this is Laura Kiramonica. I have another question because this is one that's kind of near and dear to my heart in the role of mobility. I was surprised that there was not a significant difference with the mobility interventions related to getting the patient up at least 3 times a day and increasing the distance walking. Were you surprised at that outcome, and why do you think that didn't show yet to be a significant intervention?
Yeah, surprised, probably underestimated. I was highly disappointed because I think we have perhaps given that part of our practice away. So do we refer people to PT? Do we send them to PT? That's one possibility. The other possibility, although the staff say that they don't agree with me. The other possibility is that they just they do it but don't document it. And that's also worrisome for me because if we value it, we need to be documented as part of our practice. So those are my thoughts on that.
Thank you. That helps me to again, realize that it is a major contributor. It's just that it didn't declare itself maybe because of the documentation. We also talked in the past about the fact that these kinds of programs and this research requires more than just the champions. And you hinted at that or talked briefly about that, but I know that you've shared with me about the role of leadership. Can you talk a little bit more about the significance of leadership in a fall prevention program?
I met with each of for this study, I met with each of the chief nurses individually. There was system or corporate level support for this. Paul Conlon talked at our Train the Trainer program about the passion and commitment to this. So there was very senior level leadership support. I think the leadership supports that in general, excuse me, not just for this study, but in general, that we have work to do in is what is the nurse manager's role in promoting use of evidence to guide practice at the point of care delivery, whether it's for fall prevention or other evidence-based practices. And I think they're setting expectations around that are really critical. Although I have no data from this study to support that, there is data that we published one paper from an AONE-supported study around that.
I think we talked something about what tool, and you said what leader.
What tool? I'm sorry.
Yeah, remember we talked about, I was asking about which tool would you recommend, and you said, tell me about the leader.
I'm sorry, so ask your question again.
No, when we were talking, I think I was asking you about which tool, and you were saying, tell me a little bit about the leader of the unit, as opposed to the different tools, which does the Morris tool versus the Hendrick 2, and you said, tell me a little bit about the leader.
I'm sorry. So about the fall prevention tool.
Okay.
I don't have in front of me exactly what fall prevention tool these sites use. I think it's the Morse Fall Scale. But the fact of the matter is, it's not about the tool and the score. It's about, do nurses look at each patient's risk factor and do something about the risk factor? Okay? So that's where I think we're going to get more gains, is putting in place evidence-based interventions to try and minimize or mitigate each patient-specific risk factor. It's dismal to me that we have this much work to do around mobility in med-surg units when we are addressing early mobility in ICUs. So it kind of goes back to your previous point as well. So I am not sure it's about which tool we use, rather it's about what are the risk factors, and our nurses looking at those risk factors and not just the score, putting a sign on the wall, and doing some other general things, but are they doing patient-specific risk mitigation interventions? So I hope I answered your question.
You did, and would you also point out a little bit about the risk associated with the fact that the patient had fallen, previously, within like the last 30 days before hospitalization or on hospitalization? Did that come up?
Right. So we have, I just didn't put that in this set of slides. So one of the risk categories, like the mobility risk category, we have a risk category on previous falls. So if they have fallen previously before they were admitted, what were the conditions, and did the patient and family understand those? If there was a previous fall in the hospital, have they done a post-fall huddle to address preventing that fall in the future and looking at contributing factors? So we have a whole section on that too. I just didn't put it in this presentation. I would tell...
Marita,
yeah, go ahead.
I'm sorry. I had a question that came in on the chat feature asking if you could clarify the effect the interventions had on the total fall rate before and after.
Sure. So the total fall rate went down 22%. The p-value was 0.09, and that N is 13 because the fall rate is at the unit level.
Great, thank you.
Yep.
Paula, do we have any other questions in the audio queue?
And there are no phone questions at this time.
Okay, thank you. Just a reminder to submit your question. You can either select *1 on your phone or submit via the chat feature. I just want to make sure we've answered all of them in the chat feature, and I believe we have.
Dr. Titler, did you do some training about the post-fall huddle? Was there, a recommendation that all of the staff members, convene as soon as the fall happened after the patient was cared for? Can you talk a little bit about that?
Yeah, we did some recommendations around who should attend, when it should happen after the fall, and what they should discuss, and that they should look at what risk factors were present and what interventions were actually in place to mitigate those risk factors, and to look at going forward what were they going to do differently in terms of patient care. And the sites, at least when I did outreach to the sites, really appreciated having a little bit more structure to the post-fall huddles, look at patient-specific risk factors. Then, Margie Reynolds has a question, but she's on mute.
Okay, that would be *1 if you would like to ask a question.
Okay.
And we'll take that question.
Marita, I was going to comment about the tool. And actually, two of the sites use the Morse, and one site used the Heinrich tool. And I would absolutely agree with you that I think in the experience we have in the system that the tool is actually almost an aversion to thinking about more thoughtfully, mindfully about falls, because it's a matter of, I think, we've heard this from clinicians and we kind of see it, is that using the tool is perhaps just a process to get through on a regular basis, and once it's a matter of completing the tool and then you're done, instead of thinking critically about what that tool's telling you or what the risk factors are and really matching the intervention. So I think turning that around was what happened in this study, is trying to get beyond that tool, and we've thought about completely doing away with the tool. So just a comment.
Yeah, and I think the clinicians do need something to help them identify what the risk factors are, but it's not about ticking the box and having a score. It's really about what risk factors are present. The that I might have Bob Ripley comment on is, I think there were two areas that we could have done better in, but we kind of ran out of time. And one is more focused intervention on the pharmacological component. We had great quick reference guides for that. We had some engagement of pharmacy around that. But, what I learned is this risk factor fall prevention bundle is pretty big. And the two areas that I believe we didn't give enough attention to were the cognitive piece, that is the delirium screening and referral or intervention piece, and the medication piece that I think we could have done more with.
Marita, this is Bob. I'd be happy to address that just for a minute or two. The medication risk portion of this was a bit of a challenge because the literature is robust with medications that we know put people at great risk for falling. At the same time, the literature is not very robust, but there are some reports of medication reduction initiatives in patients that were at risk for falls or who had fallen. And unfortunately, over time, a lot of those patients had a lot of those medications restarted again. So there does appear to be some resistance to modifying patients' medication therapies, even though the risk is known. I think that one of the things we did try to focus on was to not make things worse by adding more medications to the patient's regimens. We challenged people to think very critically about adding medications for sleep when the patients weren't on medications for sleep that prior to being admitted to the hospital. And I also think that is a challenging it's a challenging intervention because it really does bring three different professions together to have conversations. And I think it is a challenge to bring pharmacy, nursing, and physicians together to have conversations that can thoughtfully impact a change in medication therapy for a brief acute stay in a hospital oftentimes. So I don't think we've actually figured out how to do that well yet. And I would agree with Marita that it is an opportunity for us to continue to look at.
I would also say, Bob, that some of the units actually went to, quote, Ambien-free zones. And they did that, meaning that we weren't going to prescribe Ambien for patients who hadn't historically been on it at home. We weren't going to, right. So
that's good to hear.
Yeah.
Thank you. I have three questions, actually, that have just been submitted on the chat feature. The first was, are there any organizational differences across the three sites that may have influenced the uptake of the patient-specific interventions?
Can you repeat that again? I'm sorry.
Sure. Are there any organizational differences across the three sites that may have influenced the uptake of any of the patient-specific interventions?
Well, that's why in the multivariate analysis, we looked at severity, case mix, index, age, and RN skill mix. Those were the ones that were consistently significant across use of the risk-specific interventions. Severity was significant, at least in the slide I'm looking at, on only one of the interventions. Case mix index, as you would expect, was significant, as was age. So those covariates are what we looked at to try and at least address that. I'm not sure if that's exactly what this person is asking.
I'm not sure. If that is not the answer to your question, please post again, Dr. Wilson, and we'll get that answered for you. In the meantime, another question has come in. What, if any, role did geriatricians or geriatric APNs play at preventing falls, and did you have these types of providers involved with your study?
We did not have geriatric APNs on our study team. I did have access to geriatricians. We talked with the hospitalists on the units as they were there. The unit-based change champion, if there was a geriatrician delivering care, geriatric and MD, delivering care, they often had those conversations. For example, one of the change champions says she met with the geriatrician every morning and actually looked at the patient-specific risk factors. So, what we really did was set forth some implementation interventions, and then some of the units actually took this a little bit farther, which I think is great.
That's great. Could you speak a little bit about patient engagement as part of the process?
Yes. Well, the nurses engage the patients by helping them understand, in some cases, what their fall risks were. Now, one of the posters we had were about, from the Patty Dyke studies, were the quotes from patients so that perhaps the nurses would understand the patient's perspective better. We actually have submitted a study that we're going to resubmit. It was scored well but not funded to really understand the patient's and family members' perspective about their fall risk from a variety of different types of units and adult age groups. So in terms of patient engagement, I don't think we certainly did not engage them at a level that we could have as the research team.
Great. Well, this has taken us to the end of our chat feature questions. So thank you to everyone who submitted a question either via the chat or on the audio line. And, of course, Dr. Tytler, we want to thank you and your team for participating today. Laura Karamonica, not only for serving on our National Advisory Committee, but for serving as the moderator. We thank you.